So we're starting with the second part of our hematologic lecture. And I want to talk a little bit about these lab values that my guess is some of you don't ever look at. Am I right about that? So hopefully with this you'll have a better understanding of what it is that you're seeing here. So these are called the red blood cell indices, and they're specific additional information about the red blood cell count. So you get the total red blood cell count, you get the hematocrit and the hemoglobin. This is information about each individual cell. So the MCV is the mean corpuscular volume, and corpuscle is an old word for cell. So it's just talking about how much volume is in each individual cell. So instead of being measured in milliliters or liters, it's measured in femtoliters, which is a little teeny tiny part of a liter, because we're talking about how much volume is inside one individual cell. So it's a little tiny amount. So the normal level is 80 to 100 femtoliters. Then the mean corpuscular hemoglobin is how much hemoglobin is in each individual cell. So you know you get a hemoglobin count in your CBC that tells you how much hemoglobin is in the bloodstream overall, like 12 to 15 grams per deciliter. This is in each cell, so 27 to 31 picograms, again a little teeny tiny part of a gram in each individual cell. And then the mean corpuscular hemoglobin concentration is kind of like the hematocrit for the individual cell. What percentage of hemoglobin is there per the volume of the cell. So what this does is it gives us additional information when we're looking at patients with anemia to discern what type of anemia they have.
So what was the difference between the MCH and MCH?
So MCH is just the amount of hemoglobin, the weight of the hemoglobin in an individual cell. The hemoglobin concentration is the relationship of that hemoglobin to the total volume of the cell. It's kind of like the hematocrit, only at the cellular level.
And what was MCV?
MCV is the volume of each individual cell. How much volume is contained inside that cell. So, yeah, of everything that's inside the cell. So it's really oh, I just had another thought here. It's an indicator of size. It's an indicator of size. So the more volume there is, the bigger the size. So that's actually our next slide. So MCV is the size. So if you have an elevated MCV value, if that MCV number is increased, that means that you have a larger cell size, and we call that macrocytic. So when we're talking about anemia, you've heard of macrocytic anemias, so that's how they tell. They look at the MCV and see that that number is increased, means the cells are larger. A small number means microcytic, a lower value for MCV. If it's below normal, then you have microcytic cells or small cells. And then the MCH gives us information about the color, because the hemoglobin in the cell, in the red blood cell, is what gives it the color. And so I've never seen anemia referred to, or any kind of a cell that had too much hemoglobin in it and was called hyperchromic. But what we're concerned about is when people have a low MCH, so the number is decreased, so they don't have as much hemoglobin, we call it hypochromic. Okay, so you can have a hypochromic anemia. Another value that we look at, and we'll go back and give some examples of all of these, but another value is the RDW. That's the red blood cell distribution width. And what that's talking about is the variability in the size of red blood cells. So although your red blood cells are very similar in size, they're not all identical, right? There's a certain amount of variability in the size of your red blood cells. There's 11.5 to 14.5% variability in the size of your red blood cells. That's a normal range. Well, if there's more variability, that number is increased. That percentage is increased. Now it's increased whether you have a lot of variability because you have a bunch of small cells, or if you have a lot of variability because you have a bunch of big cells. Either way, if you have microcytic cells or macrocytic cells, you have more variability in the size of your red blood cells. Does that make sense? It doesn't matter if it's microcytic or macrocytic. If this number is elevated, it just means that you have more variation in the size of your cells. Okay? Are you with me there? So if this value is elevated, you know there's more variability, but this value doesn't tell you whether it's a microcytic problem or a macrocytic problem. It's going to happen this number is going to be increased either way, because your cells are just going to be various sizes, whether some of them are really small, some of them are medium small, some of them are normal, or some of them are normal, some of them are medium big, and some of them are really big. Either way, there's more variation in the size of your cells. So what that does is it lets us know by looking at anemias over, thousands of slides under the microscope, what we've seen is a relationship between a problem that the patient has and the type of cells that they develop as a result of that. So iron deficiency anemia gives us low values in all of these. Now, iron is an important component of hemoglobin, and if you don't have enough iron, you can't make hemoglobin. So the hemoglobin value is decreased, the MCH is decreased. If you don't have as much hemoglobin in the cell is smaller, so the MCV is decreased. So you have a microcytic hypochromic anemia. That's what happens when you are iron deficient. So if we look at your red blood cell indices, we have a patient who we know is anemic. We look at the red blood cell indices and we see that these are all decreased. Iron deficiency should jump to the top of your brain. Now there are maybe other causes, there are many other causes of anemia besides the ones that are on this slide. These are just some of the most common ones that we encounter. So if you see microcytic hypochromic cells, iron deficiency should be one of the first things that you think of. Okay. Vitamin B12 and folate do a different job in the development of red blood cells. They're not involved in the hemoglobin at all. So the MCH is normal. Even if you're deficient in B12 and folate, that doesn't affect your hemoglobin development. So the hemoglobin value in your cell is normal. But what it does, what those components are involved in is completion of the cell, closure of the cell at the end of development. And so what happens is the cell sits in the bone marrow, growing and growing and growing, continuing to grow as it's waiting for the B12 and the folate to come and finish it off. So it gets bigger and bigger and bigger. Finally, the bone marrow says, well, we can't wait any longer. We're just going to push it out into the bloodstream. So we're going to end up with macrocytic cells that there's no problem with their hemoglobin. Okay? And it's either or. You don't have to be deficient in both. You can be deficient in vitamin B12 or deficient in folate, either one, and end up with a macrocytic anemia. Now, chronic renal failure, why do people with chronic renal failure have anemia? They're not producing erythropoietin. So erythropoietin stimulates your bone marrow to produce red blood cells. Well, if you don't have as much erythropoietin, you're not producing as many red blood cells. But the red blood cells that you're producing are just fine. There's nothing wrong with them. They're not deficient in anything. So in the anemia of chronic renal failure, these values tend to be normal. Now at the end stage of disease, you might see something different, but at least at the beginning, they're going to be normal. So by understanding these, when you look at the red blood cell indices, you can say, well, gosh, this patient might have an iron deficiency anemia, or this patient might have a folic acid deficiency. So it helps you narrow down what kind of anemia they have. Here's just another slide that gives some additional examples, looking primarily at cell size, microcytic, normocytic, and macrocytic. Now, I mentioned end-stage renal failure. Well, the anemia of chronic disease, we don't really know why this happens, but as people have chronic diseases, we see that they develop a microcytic anemia. And that can happen with renal failure too. But initially, it's going to be normocytic, normochromic. Okay? So there are all kinds of tables that show these kinds of values in anemia, so that can help you narrow down what you're looking for. Make sense? A couple things about iron itself. So most of the iron in our bloodstream is bound to the hemoglobin molecule. And then a portion of it is bound to other circulating substances, ferritin or hemosiderin macrophages, and also in the liver, hepatic parenchymal cells. Parenchyma is just the tissue itself, so liver cells. And then about 3% is lost daily. So there are a number of diagnostic tests that can be done to look at iron. Iron level tells us the amount of iron that's being carried through the bloodstream by that transferrin. And we can actually measure the transferrin level that tells us how much carrying capacity there is in the bloodstream. Transferrin is a protein that's produced by the liver. So if you don't have good liver function, you're producing less transferrin because it's a protein that's produced by the liver. Ferritin is the storage form of iron. And there's some things that can make it look artificially elevated. And then total iron binding capacity is really a measure of the proteins that are available for binding to the iron. So for example, that transferrin protein. So if iron level is low, there's more proteins available for binding because there's no iron on them, and that'll make the TIBC be elevated when somebody is low in iron. Okay. So with iron deficiency anemia, commonly what we see is a low serum iron level, we can measure that, a low serum ferritin, which is that storage form, and then an elevated TIBC. So again, various conditions will cause various combinations of these diagnostic tests. So as we put them together, we can see what is most likely the case in this patient's scenario. Now, just a little note about patients in intensive care units. Not all of you obviously work in intensive care, and if you're nurse practitioners, you're probably most likely going to be working outpatient. But just to keep in mind that when we draw patients' blood, we put them at risk for anemia. And there's been a lot of research looking at ICU anemia, where we draw so much blood on patients, do so many lab tests that we actually make them anemic. So we always want to think about, especially whether it's inpatient or outpatient, if you have chronic patients in the outpatient setting where you're drawing a lot of lab values, to always be stopping to think about how pertinent is this? Is it going to direct treatment? Is anything going to change if I know the value of this lab test as we make decisions about that? So we'll stop here, and then I gave you the anemia case study, so if you want to pull that out, we'll take a look at it.